All right, we seem to have leveled off a little. Hello and welcome, everyone. A few more may join, but we are glad to have you all here with us today in our back to school task force meeting. Glad to welcome educators and others to our discussion. We hope to have lots of questions and answers for you today. We have some updated information about COVID, the pandemic, what we're seeing in schools and the hospital, and some of the recommendations that will perhaps apply to your school this fall. We are very glad to have you. Our panel today includes, for those of you who have been with us before, some of the same faces you may have seen in the past. We have representatives in a variety of areas, and we are hoping to answer your questions that may apply not just about the infectious diseases themselves, but in how this is affecting your kids in classrooms. I'm Tony Whitaker. I'm the Division Chief in Developmental Pediatrics at Bonheur and University of Tennessee Health Science Center, Department of Pediatrics. We also have with us Dr. Sandra Arnold as the Division Chief in Pediatric Infectious Disease, also at Bonheur and University of Tennessee Health Science Center. Dr. Cynthia Cross, Division Chief of Pediatric Hospital Medicine at Bonheur and at Bonheur on the Move, and School Health Services at both Bonheur and UT Health Science Center. Cindy Hogg is our Director of Health Services and Community Outreach for Bonheur. And finally, Dr. Mary McDonald is the President and CEO of MCD Partners Consulting and a founder of the National Leadership Council at Bonheur. So again, welcome to our panelists and to our participants. We will be taking the Q&A after we have the presenters give a little bit of background information and updates. So if you want to go ahead and put your question into the Q&A, that's perfectly fine. We will monitor those as we go. We'll get to as many of them as possible, and we will have some offer some ways to get in touch after, and we'll let you know about that toward the end. So first, if everyone doesn't mind, let's kick it off with an update from Dr. Sandra Arnold.
Hi, everyone. I'm not going to say a lot to start because I think mostly we just want to be able to answer the questions that you have. Things are very, very different now than they were certainly 2 years ago, and even different than they were last year at this time. We really have a certain level of herd protection in our community now, whether from vaccination or previous infection, that is really protecting our community from serious disease. And this is what we've been waiting for a while, because this allows us to live our lives more freely, knowing that we are all still, unfortunately, susceptible to getting COVID, even those of us who have had 4 shots like I have. We can all still get COVID-19, especially with these new subvariants, BA4 and BA5, but with some level of immune memory and protection, most of us are protected against serious disease. And so the CDC's way of monitoring the level of transmission in the community is they're still monitoring case numbers, but really it's more about hospitals now and whether hospitals are being overwhelmed. And our main reason for shutdowns and all the other different mechanisms that we used to keep cases down in the past were to keep the pressure off hospitals, keeping people from dying, keeping people from entering the hospital. And this is something that is a lot less common now, even though the hospital, we still have 40 to 50 patients hospitalized with COVID. Of course, not all of them are in the hospital because of COVID. We are seeing really substantially less pressure on our hospital system. So we're not going into lockdown anymore. We are not forcing non-pharmaceutical measures on people anymore. But you know, schools are still a special place. It's very important that children be in school, in desks, in classrooms learning. And so what can we do to help keep kids in safely in their classrooms learning? And that's what we do want to address today. I have substantially shortened the infectious diseases section of our guidance document, and I just want to draw attention to a few things that we're really emphasizing in the document. So the first is we continue to strongly recommend vaccination, even though there is some level of immunity from past infection, and so many people have had infection, many of those people with Omicron in the last year. The additional boosting and broadening of immunity and protection from vaccination in combination with past infection is really can't be overstated. And so, a single infection is certainly not as protective as 2 vaccines in an infection, or 3 vaccines, or even multiple infections. And so we continue to strongly push vaccine. We're hoping that there will soon be a booster for the fall that contains information that contains immune boosting proteins, or mRNA that codes for proteins that will protect against BA4 and BA5, but in combination with the ancestral strain of the spike protein from the original virus, because we don't know what the next variant is going to look like. And the way the variants have come up is they've basically deviated from the original strain in many different ways and in many different directions. So another variant could pop up that looks more like the ancestral strain, or more like Delta or Alpha or Beta. And so we wouldn't want to just be focusing on Omicron, assuming that drift will continue to occur from this Omicron base. And so we are going to recommend that everybody get that vaccine. Of course, we cannot require it. But we would, encourage you to encourage your students and staff to be vaccinated. We are also recommending masking when cases are high, which they currently are. Transmission in Memphis is relatively low currently, but all around us in other counties in Tennessee, transmission is moderate to high. And so we're expecting cases to surge, again, hoping that hospitalizations do not, but there will be cases. And so we're basically saying that in situations where you're crowded in with a lot of people, which is school, that you can make a good argument for mask wearing. Again, not required, but should be encouraged. For anyone who really wants that extra layer of protection beyond that which their immune system provides, because their immune system is going to provide protection against severe disease, but it's really not going to provide protection against infection. Just as an example, my husband and I were in the Pfizer trial. He has had 5 doses of vaccine, including an Omicron, which he got in April, and he is recovering from a very mild case of COVID, but COVID nonetheless. So infections are occurring among people, even the most highly vaccinated among us. We are still encouraging testing for people who have signs and symptoms of COVID. And obviously that can be done at home. It's a lot easier now. Just a warning that sometimes very early in infection, right when symptoms start, the rapid antigen tests that you can buy at the store, and even the ones that you do at a pharmacy, if they're not PCR tests or nucleic acid amplification tests, what are called NAATs, they can be negative early in infection. And so most people do need to repeat their swab the next day or the day after in order to get a positive. Sometimes it can take many more days than that. And we're going to have to decide, everybody is going to have to decide on their own how many days they want people, people need to be tested in order to return to activities. I would, and we can talk about that. I'm sure somebody's going to ask. And we should be notifying people when their children have come into contact with COVID-19. I think given the level of protection in the community, the CDC is still making a recommendation that if you've had infection in the last 90 days, or if you're vaccinated, that you don't have to quarantine at home, but that you can wear a mask and continue about your business. I think that because so many people have been infected and have some level of protection, an alternative to that could be to allow everybody who is exposed to wear a mask and continue to go about their business. And I think that, allowing people who have been exposed into school when they're asymptomatic, as long as they're masking, is probably the best way to keep kids in school. Some people may choose not to have anybody wear masks for any reason, and that's also okay. Everybody gets to decide for themselves, or at least each school gets to decide what they're going to be. But one of my suggestions would be trying to limit excluding children from school who have simply been exposed to COVID-19. As many people have said over the last 2 years, we don't do that for flu. And in terms of the numbers of cases in hospitals and the numbers of very ill people, we're starting to get closer to flu numbers. And so maybe we should be treating this more like the flu flu now. And even though we haven't separated people out with the flu, with masking and things like that, it is something that you could do to try to, since this virus is so much more contagious than flu, limit its spread within schools and limit absenteeism. And those are the main points that we're making in the document. A lot of the things that were in there about distancing, obviously we haven't really been practicing major social distancing for a long time. All of those things, a lot of that has been removed because we know that it's not really practical, and we haven't really even been doing that in the past year. But obviously the farther apart people are, the less likely they are to catch COVID from each other. So in situations where it's possible to keep distanced, it's probably a good idea to keep kids from getting sick and missing school. So that's pretty much what I have just as an introduction, and we'll be happy to discuss any of these things further when you guys have questions about it.
That was a very great summary. Thank you. And Dr. Cross, would you mind giving a brief update on what you've been seeing in the hospital?
Sure. So unlike schools, the hospital environment still requires one of these. We all still mask up at the hospital. If you're in your own office, you can take the mask off, which is where I am with my door shut. What a difference a year makes, right? Because this time last year, adult side of our system probably still having 100 or so folks a day in the hospital, and maybe half or more of those were intubated in the ICU. Here we got to the 20s to 30s for daily numbers for COVID, and now we're in single digits, which is nice to see. When our kids get admitted, many of them are young, and when they get fever, they just don't drink well. So some of these kids are here because they're dehydrated with COVID. And not necessarily because their lungs have really taken a big hit. But we have seen kids who have had pretty severe illness and end up in our intensive care unit. And I don't know our exact number of deaths, but as recently as 2 weeks ago, one of our long-term patients succumbed to COVID. So it's still out there, still causing issues. We also are seeing a number of other viruses, and sometimes it makes it difficult to know if COVID is the cause of the illness or if it's another virus, because many folks who got COVID didn't know they had it and will have a positive test, but that test can stay positive for several months. So if during the interim you contract another virus, then sometimes it's difficult to tell. Now, some of those viruses have very distinct findings, and you're fairly sure it's adenovirus, but sometimes we can't tell the difference. And so basically, the take-home point, many fewer kids are getting admitted to the hospital with COVID, which is great, but it's still in the community and still requires a bit of our attention. And we can take questions more specifically about it later.
That feel free to ask us about anything related to, health and going back to school. I mean, we have a school nurse, and I'm happy to talk about, a lot of people have questions about monkeypox and other things. So if we can't answer it, we can't answer it, but you're perfectly welcome to ask about almost anything.
Thank you. And Cindy Hogg, would you give us a little update about your role and what you're seeing in the schools?
Yes, thank you. So this this week is the week that most schools are back. I'm going to turn my camera off so that my voice will not be cutting in and out.
It's still cutting in a little bit. Give it a try.
We are seeing some school districts choose to not mask as what's been happening, masking when the children and the parents want them to be masked. Some districts are continuing. Some of our schools are keeping their safe rooms and some are not. And what we are just asking across the board, the best advice to give parents and teachers is to stay home. If you're keep your child home if they are sick, if they're having symptoms, having fever, please keep them at home until they're fever free for 24 hours without taking any medication. And if you yourself are ill, do not come to the school to sit with your child for lunch or do any of those other activities that that parents sometimes do. So that I think is the most important thing, of just stay home if you're sick.
Wonderful, thank you. And it did help for your camera to be off, but join us again when
Thank
you want to. And I'll say from a developmental standpoint, I won't tell educators about the education of children, but certainly from a developmental standpoint, considering kids with developmental disabilities or those that have had challenges learning, particularly, these health effects and health risk exist for them too. And for some of them, the medical risk or health risk are higher for certain kids with developmental disabilities. So we maintain our concern. I appreciate very much what Dr. Arnold said about reducing absenteeism or working not to keep kids out of school as much as we can keep them in those learning environments where they can learn and thrive, but also be safe, is really why we're here, to talk to you guys and help you work through what will work best for you and for your students. And so we'll start taking a few questions. I'll ask Mary McDonald, did you have anything else you wanted to add at this point? I know oh, you're on mute.
For a reason, we'll just take the questions first to make sure we get all of them answered.
Okay.
And then
Perfect. Thank you. All right. Let's give Dr. Arnold the first. When do you think the next COVID wave will hit our community?
So, I mean, I think we're kind of in it right now. Like I said, we're surrounded by counties that have higher transmission than we do. If you look at this CDC, let me see if I can share the screen. So can you guys see the webpage?
Yes, we can.
Okay. So if you go to this webpage on CDC website, you can see, so you can see that green is low and we're green down here. There, Shelby County low, but then we also have yellow and orange parts of the state, and also similarly in places around us. And if you look at, you can also look at the, sorry, this isn't the right website, but you can look at the, here we go, Tennessee. So you can look at what is happening in Shelby County by going to this page. I find this a very user-friendly one. And it'll show us what's going on in Shelby County. It'll show us this county map. Oh, it'll show us what's going on here. Oh, forget it. I'm just going to leave it be. Never works when you want it to, but you can, what you can see is that there are some, you can see the previous waves. Actually, I have this page from yesterday from a talk that I gave, which, so can you see this? So you can see, this is actually from the New York Times, and you can see in Shelby County, you can see this is the Omicron peak here. Can you see the graphs I'm looking at? You can.
Yes,
okay.
we can.
And you can see what's going on now. So these are cases. So cases are similar to what they were. They're lower than they were in Delta and much, much lower than they were in Omicron. Over here is hospitalizations, which are really quite low, but there's definitely been a peak, and it hasn't gone away yet. Down here, you can see test positivity. So our percent of tests are pretty high. Positive tests are pretty high. And that's probably because a lot of people are testing at home, and the only people who are getting tested in places where it's being recorded are people who are really symptomatic. And so a very large proportion of them actually have COVID-19. So I think we're in the middle of a wave, but it might be a very long, broad wave. And it really just depends on how long this variant lasts. If we're going to have another variant, we don't know what's going to come next after BA.5. And so I don't really think that we know. It doesn't seem like things are going to shoot up like they did with Omicron. I think, again, we have a sufficient level of immunity here, but cases are probably actually higher than this, and a lot of them are not being recorded because of at-home testing. So
and that's Dr. Arnold, just because it gets a little small for the participants to read, can you give just a quick time point of where yeah, there you go. That may help a little bit. Just indicate, if you would, where the time points are. I see them now, but it might help.
Yeah,
for
so
folks
this is
to-
May 2022 over here. So
Okay.
this is present right here, and this is December. So this is the Omicron peak that started in the late fall right here. And it's the same all the way down here. Sorry for not making that.
No,
big.
that's perfect. Thank you.
So
The
again,
type-
some of this difference is because many positive tests that are at many people who have COVID are not getting counted, as we know, because we're testing ourselves at home.
And actually, while you're on these graphs, if I'm not interrupting too terribly, we have a question about getting boosters, and the specific question is, when should kids under 15 get boosters? But would you mind speaking a little bit to your thoughts around booster timing? Maybe it matches this graph a little bit.
Yeah. So what I would say is that the recommendation is, so a booster, the terminology is not stupendous, because really what we're talking about is a third shot, and the third shot is really needed. 2 shots is not going to do enough for you. What the third shot does is it broadens your immunity to give you better protection against a broader range of variants of the virus. And so everybody should have a third shot. So even though, quote, fully vaccinated is 2 shots, up to date on vaccines is 3. And instead of using the word booster, we really should be using the word third shot. There are certainly plenty of other vaccines where we have 3 shots. And if we don't have 3 shots, it's because we've gotten rid of the middle one, because it's really the one that happens months afterward that improves that immune memory that you have, and broadens the immunity, what are the B cells and the T cells that produce antibodies and help fight off viral infections, broadens their ability to recognize variations in the pathogen. So like when HPV vaccine first came out, you got it at 0, 1, and 6 months. And 0, 1 month got you immune very quickly, just like the 2 doses of coronavirus vaccine, but you really need that 3rd dose to consolidate that immune memory. And they've actually dropped that middle dose, because it's been found that really what you just need is a dose that happens many months after the first one. And that 2nd dose, while in coronavirus is good because it gets you immune quickly, you really need that 3rd dose. So everybody should have that 3rd dose, and it should be 5 months or more after you finish your primary series of 2 doses.
And to that end, I'm going to modify a question here a little bit. The versions of vaccines that are available right now are the same ones from approximately a year or so ago. When do we have a good prediction on when the newer versions will come, and what are your comments on mixing them, and what recommendation at various ages? I know that's a lot in one. Sorry.
It's a lot. That's okay. So this fall, which is very vague, I don't think anybody knows. I mean, you guys know as much as I do from listening to the news and hearing what everybody is saying. Soon, hopefully within the next couple months. I mean, the big concern, of course, is that by the time we have this Omicron BA4, they've had this Omicron booster for a while, but we didn't give it to everybody because they were testing it. And now they're not going to go through and test the Omicron subvariant boosters. But the concern is, of course, that there'll be something else circulating by the time we get that. And, that this is, we're doing a lot of playing catch up with this. So it's suboptimal. It would be great if we had it right now, because right now we're experiencing BA4 and BA5. Hopefully in September sometime, but they have to, change production and ramp it up and get it out there. And we have to figure out who's going to pay for it too, because there's some discussion about whether the government's going to buy those doses. And like I said, that I get this from the news the same way that you guys do. I don't have any insider information. What was the second part of the question?
I think we were the ages, and basically we've got a couple of questions on the youngest kids and then kids under 15 also.
Right. So anybody over 5, a 3rd dose is approved so far. And so they will, well, of course, the littlest ones for Pfizer, it's 3 doses already. And then, but for a 3rd shot for those whose primary series is 2, for everybody over 5, once it's been 5 months, you should get a 3rd dose, no matter what your age is, as long as you've had 2 already. And, you know, and if you wanted to wait and only get one and they get one 6 months later, that's probably okay as well. The threat isn't there, but you know, you're not going to get protection as quickly by doing that. So I would recommend 3 doses. In terms of mixing, you know, the jury is still out on that. There are a lot of people who are mixing. There's certainly no harm to mixing. And if you've only gotten Pfizer and you want to get Moderna, just in case it's better, it's certainly not going to be worse. I think that that's okay. Some people have talked about using the Novavax vaccine as a booster since it is not an mRNA vaccine and maybe it's less likely to cause all the inflammation that leads to myocarditis. If you didn't have myocarditis with those first 2 doses, only 3 or 4 weeks apart, you're not going to get it when you get one 6 months later. That's really not been a big issue. So it's really whatever you can get your hands on. There's certainly plenty of Moderna and Pfizer vaccine out there, so you can take your pick. Nobody's making any recommendations for using heterologous vaccines definitively because there really isn't enough data on it.
And I'll give you a question off your own answer about side effects. Are we seeing different types of side effects in age groups or not so much?
Not really. I mean, the myocarditis is the side effect that everybody's the most concerned about. And even that has turned out to be a mostly non-serious thing, unpleasant, but non-serious. And it's less in the younger kids, right? It seems to be that there's this age group in the sort of mid-teens to, you know, 30-ish, where, you know, these sort of really healthy people with really sturdy immune systems that are having this excessive immune response with a lot of systemic inflammation that's leading to this. And actually, the younger you get, the less likely you are to have these side effects. So the vast majority, and in the vast majority of people, the side effects are the typical local side effects of, you know, sore arm, maybe some fever, headache, fatigue, all of that stuff. And I haven't really been seeing that those are worse with subsequent doses. It seems to be that the second dose seems to be worse than the first, but then subsequent ones aren't as bad as the second dose. So
Okay.
I don't really think people should worry. And I just want to reiterate, a lot of people keep saying we don't know enough about these vaccines. They haven't been around for long enough. We need to remember that more people have received these vaccines in a shorter period of time than pretty much almost any pharmaceutical in the history of medicine. And that is where we get our information from. It's a numbers game. It's not a time game, right? We're not ticking time bombs. There's nothing from those vaccines that's left in your body, probably even a week after, other than your immune response. And so it's the immune responses that make you feel unwell or give you side effects. And then when those subside, they're gone and all the vaccine components are gone. So anything that we're going to see as adverse events related to these vaccines that occurs, I mean, we can even see, we've seen things that occur at a rate of 1 in 10 million, probably, when you think about the number of people who have received these vaccines. So we know everything we need to know about the vaccines that are currently available and have been given to a couple billion people now. I mean, that's just never happened before. So we don't need to be asking those questions anymore. They've been answered.
That's a very good point. And I will open the next one up, still maybe Dr. Arnold, but to others who may have some other information on accessibility for these vaccines, especially for the younger kids and for communities where access may already be a little difficult. Do you guys have information on where folks can get vaccines for all ages, but especially the younger ones?
Right. So some of the pediatric offices are stocking them, but a lot of people don't necessarily have access to all the primary care pediatric offices. The best place to tell people is the health department. The health department has it for all the ages, and they have clinics and they have their times posted. It can be difficult, of course, because those are during typical working hours. After hours is a little bit more difficult. And, you know, for people who have jobs like us who can't take off work in the middle of the day, we could certainly find out when the health department is open for giving vaccines, and if there's a significant demand. I don't know whether they'd be willing to offer them on the weekends. Coming up on this weekend, it's a good segue. So we've been doing Cindy and I have been spending a lot of time together. this Sunday is our last preschool vaccination clinic. So kids at the Memphis Shelby County schools, when you're coming in and registering we are offering vaccines, actually any vaccine, COVID and other vaccines that kids need for schools. So if you're going to tell people to go, tell them to get there early, because we probably have to shut off registering people around 11 or 12. But we have given vaccines to hundreds of kids. We'll vaccinate parents against COVID as well. And I guess if they're really popular, we might be able to talk about doing more of them. But as of right now, I can't promise anything. But this Saturday, August the 6th, is the last one. And it's and Sarah can confirm this, I believe it's at the Teaching and Learning Center on Union again, as
Yeah.
the same that we had last week. Not this past weekend, but the weekend before.
Yes, and we have a list of all those locations from the Shelby County Health Department. We can include in the email we send out tomorrow as well.
Awesome.
And the times. They are doing some off hours times as well.
That's great.
And while we're still on vaccines, let me get you.
Can I just
up.
say
Oh, yes, go right ahead.
add
Sorry.
one thing,
You're going to have to
Thank
turn off your camera.
Sarah?
Yeah.
I'm sorry.
Camera off, but
Sorry.
then speak away.
We just had some families from Mrs. Okay. Okay. I apologize for this internet.
Now we can.
We have had some families coming to these events from Mississippi into the Tennessee immunization system. So we are having to turn those families away. So I just want to remind you that it is for Tennessee students in Shelby County.
Thank you. That's
And
really,
I will,
really important.
I'll just repeat that. I think I got it. It's for Tennessee, and it has to do with where the vaccines come from and where they're supposed to be. So while we want every other state person to be vaccinated, it can't be at these particular events. Is everybody nodding that I'm gathering that correctly? So thank you, Cindy, for trying your best to tell that. Could I boost us up, so to speak, to an older age range? I have a question about teachers. We talked about the 3 doses and who gets those. But thinking about this question about a teacher over 50 who's had 3 doses, would you recommend the 4th dose before school starts or wait for the new booster? Oh, you're on mute.
Yeah, sorry.
Yeah, sorry.
Weird thing. So everybody is asking me this. I had this exact conversation with a friend of mine this morning. I think at this point, I'd probably wait. But I don't think there's any harm in getting one now and getting one in a couple months either. So it's really up to the individual. We really don't know what the right answer to that is. I think the most important thing is it won't harm you to get 2 of them. If you want to get one now, just in case the new shot takes longer to come out than we're expecting it to. I certainly would never discourage anybody from going out. I've had a 4th shot, but I had it in April. So it's really a personal choice. What I would say is there's no harm in getting 2 doses within a few months of each other. So whatever makes you feel more comfortable.
And regardless of age, if a person is eligible for higher risk status and has concerns, would you agree that applies for them as well?
Absolutely.
Okay.
Higher risk people should already have 4 doses by now.
Okay. And just a prediction, this may be a crystal ball situation, but do you think we'll still need these every 5 to 6 months going forward?
Goodness, I don't know.
Okay.
I hope not. I hope that with more herd protection, that the emergence of variants will slow somewhat. We also don't know what is going to happen in terms of, will there be some seasonality? I mean, wouldn't that be nice if we had a coronavirus season? Like we have a flu season, then we only would have to do it once a year. It doesn't seem like that's going to happen. I think it really just depends on what we see with the emergence of variants and subvariants. And I think it's still a little too soon to know exactly what the future holds. I mean, the good news is that we have this technology and we can do it. The bad news is nobody wants to get an extra shot twice a year. But I mean, in the grand scheme of things, it's not it's not the most burdensome thing, but I wish that I knew.
Okay. And I have a question about vaccine timing and immunity. I'm going to rephrase just a little bit to make it a little more broad, but if someone hasn't had a vaccine, they start their series now. Can you remind us about how long it takes for that to be fully vaccinated?
2 weeks after your second dose. So it's 3 weeks between the Pfizer doses and 4 weeks. No, 3 weeks between the Moderna doses and 4 weeks between the Pfizer doses. And 2 weeks after that, you're considered protected. You're considered fully vaccinated. But again, just to reiterate, when you look at what protection you get from 2 doses against Omicron and subvariants, not very much. You really need at least a 3rd dose to really broaden the protection that broaden your immune memory so that you have a much better level of protection. I'm talking about against infection at all, but also against severe infection. The immunity, the protection against severe infection has dropped off a bit, even with 3 or 4 doses with these subvariants, but it's still very good. So anybody who's getting vaccinated, even though it says 2 doses is fully vaccinated, really you need 3.
Okay. And I appreciated your picture with the green and orange boxes to show the community transmission. So it feels like that now would be a good time if you needed to start while the community in the local area is green. So that time, that adds up to be quite a bit of time. So getting ahead of the wave would be nice. Just a thought. Let me change just a little bit to testing. We have a question about how accurate the different types of tests are: home test, rapid antigen test, PCR. And you mentioned this a little bit, but just reiterate that. And then the second part of the question is, how long can a person test positive? Personally, I'm seeing a lot of folks wanting to get a test to show that they're finished. Is that necessary? And I know I did 3 questions at once, so I just want to say,
no, that's
I'll
okay.
repeat if I need to.
I'm getting these questions a lot too from friends and family. So PCRs are more sensitive than antigen tests. The fancy ones that they do in the pharmacy or in the Le Bonheur lab or something like that are probably more sensitive than the ones that you do at home, not least because nurses probably swab you better than you swab yourself. That, technique is important. But we know that rapid antigen tests are less sensitive than PCR. This is one of the reasons we use PCR, because it's going to pick up everybody. Now, it's so sensitive that you could have a rhinovirus now and have had COVID asymptomatically 2 months ago, and your PCR could be positive. So there's a downside to being so very sensitive that we know, and Dr. Cross said this earlier, that your PCR can be positive for 2 or 3 months. So access to those is more limited. It's a lot easier to get a rapid antigen test, even at your doctor's office or a pharmacy, because not all doctor's offices have rapid PCRs in their office. Some do. And they can also test flu and RSV with those. So, it's imperfect. The system is imperfect. And I can tell you that I know plenty of people who have had COVID who, even though they were pretty symptomatic with cough and runny nose and fever, who tested negative for a couple of days on rapid tests at home. And so we do need to be aware of that if you have a very symptomatic person, you probably want to repeat that test at least once. But I have heard about people who haven't been positive until they've tested themselves again on day 3 or 4. So again, it's an imperfect system, and that we do have to recognize that there are going to be other things out there making people sick, and find a compromise where if somebody tests negative, we still let them back into the school. If they've, retested after a day or 2, and you can decide which one you want to do, trying to limit the number of days that kids are out of school, letting them back in with a mask or something. I mean, we just need to be creative, I think, in figuring out, in my mind, the best way to keep as many kids in school as possible without making everybody sick, and then having everybody home from school because they're sick. I mean, it's a real balance, and I don't know what the exact right answer to that is. There are lots of things that you can do, and it might be trial and error. Let's try this first. But if we're finding that it's spreading, then maybe we have to make people go and get a PCR, or maybe you have to make people go and, wait a couple more days and stay home for 2 or 3 days instead of 1 or 2 days. In terms of how long do tests stay positive? So this is a big one. We already know PCR stays positive for a long time. You don't have to have a negative PCR test to return to activity. 10 days. If you're better, you can come back out into the general public, circulate among people without a mask on. CDC says after 5 days, if you're feeling better, you've not had fever for at least 24 hours and your symptoms are improving, that you can come out of isolation, but you still need to be wearing a mask around other people. And I think I like that. I mean, a lot of people have criticized it because you're still contagious at 5 days, most likely. But at least we're not really impacting people's lives in the same way that we were when we were making them hide out for 10 days. And this is really important when it comes to school, because the degree to which you're infectious significantly drops off after a few days. And so even though you're still potentially contagious, you should be less contagious, and hopefully that's contained by a mask. If you test negative, does that mean you're not contagious? We don't actually know that. Right. And having people test and keep retesting, saying, well, if you test negative, you're not contagious. That just encourages people to keep testing themselves. And then they worry that they're contagious and they're not getting back to their normal activities. And I would hate that to be the rule that people follow for kids going back to school, because I think that's going to end up excluding kids. Because I know people who have been rapid antigen positive for 14 days or 21 days. And we know that the amount, if you're not having severe symptoms anymore, that you're really minimally to not contagious after 10 days, in terms of having culturable virus from your respiratory tract at that time. So I'm not a big fan of using repeat rapid antigen tests to decide how long you should be out of activities, how long you should be masking for, how long you should be considered contagious. Because really the studies do not exist that tell us that when you turn negative, you are not contagious. That just doesn't exist. And so I wouldn't do that. I would still go with the 10 days, as long as you're better, as an absolute for when you can stop masking. And I'm fine with people returning to activities with masks on after 5 days, as long as they're better.
Perfect. Thank you. And I'm going to change to classroom infection procedures. Have a question about that. Do others want to say more about the vaccines? I think we've actually, let me read this one. Just a clarification, teachers, students after 5 days, can they return to school with a mask? And that sounds like what we're saying. Yes, Dr. Arnold, just making sure I'm
Yes,
answering
please.
that. Yes, please. Yes.
With
But
the
a
caveat
well,
that as long
go
as
right ahead.
we're free for 24 hours, right, Sandy?
Yes, as long as their symptoms are improving and they've been fever free for at least 24 hours. Yes, that bears reiterating repeatedly.
And actually, this might be a good time to talk about masks again, the types, and maybe Dr. Cross could help us with this one. Types of mask, whether they're fitting well, tips on mask use, because even if we're not wearing them all the time, if we are trying to get kids back in the classroom and that's part of that recommendation, it will still be important that we get that as right as we can.
Absolutely. A well-fitted mask so it fits around the face and covers the mouth and the nose. Wearing a mask down here doesn't help. Wearing a mask on your chin doesn't help. The surgical type masks are the ones that we use here. If a person is symptomatic, or for our healthcare providers who are going to be working with a known positive patient, the N95 is the best one to use. We learned pretty early on that some of the single layer cloth masks are not as effective, and the neck gaiters are not as effective, even though some of them look really cool. Probably not the best mask to use. So does that kind of answer the questions on masks?
And I mean, I'll show these medical surgical ones. I'll say that I have to tie a little knot on the string to make
Right.
mine fit well. And certainly for kids in school, faces of different sizes, depending on what they have, you might have to think about that with them. Sometimes people will cross the ear loops, and that helps in some ways, but it also might make puckered gaps on the side. So it really is important to look at it and, feel around the edges, teach kids how to kind of
Right.
just to feel around the edges and make sure it feels like it really fits well.
And make sure it's comfortable
True.
as well. Sometimes you will get a little irritation behind the ear. I have to make sure that my hand sanitizer is dry before I place my hand behind my ear to put the mask back on or change the mask, because it can be irritating. And if your child is child size, then a child mask rather than an adult mask works better, because there is a difference in those as well.
Absolutely. And touching things while we're on this infection control, maybe it's Dr. Cross as our hand washing expert. Refresh our memories on hand washing.
So the alcohol hand sanitizers work very well, but if you use them over and over again, you tend to get some buildup of residue. So it's a good idea throughout the day to use soap and water as well. If your hands are soiled from coughing or sneezing, then you need soap and water. If you go to the restroom, it's best to use soap and water once you're finished. If you touch high touch surfaces like doorknobs, handles, those kinds of things, then use hand sanitizer after you contact those. Also important to teach kids to keep their hands away from their face, their eyes or nose or mouth, because you can contact something and infect yourself that way. We don't know how long the COVID virus survives outside the body, but there are other infections out there as well where this practice is always good.
Perfect. All right. So to a question, we are running a little low on time, so I'm going to get to a few more questions right quick. What is a reasonable threshold of infections in a room to trigger closing a class, do you think?
So, in the past, we've said that if it looks like there's being spread within the school, we haven't had a lot of spread in schools, that most of the cases that have occurred in schools are cases that kids have brought from home. So I think that if we document spread within the classroom, if you've got, which is also, of course, very difficult because we don't always know who's contagious or not. But I think if you start to see more than a couple kids in a class coming down with COVID after there's been an exposure within the classroom, that might be time to send everybody home for a period of time, or have everybody wear masks, or, there are different things that you can do. It doesn't necessarily mean that you have to shut it down. But I think that, documenting spread to multiple 2, 3, 4 people within a classroom, and if they're kids who are all sitting clustered together, then you might be a little more comfortable waiting. But if they're all in different parts of the classroom, you might say, maybe it's time to dismiss the class for a period of time, give it some time, and then bring them back.
Okay.
But definitely documenting transmission within the school.
And we have a question that's a little bit, it has some details that we may have to get past some of the details because it matters about vaccinated or not vaccinated or the strain in the community at a particular time. But let me ask the general question about other precautions for immunocompromised children or even the parents of these kids who may have special needs or immunocompromised. Any particular additional restrictions or concerns about them?
Right. So these are the people that we should be trying to protect, of course. And what I would say is that we have vaccine, but vaccine is imperfect. The good news is we also have medications. We don't have as many medications for little kids, although I'll put a little plug in that we have an open trial for Paxlovid at the Bonheur Children's Hospital for younger kids. So we can treat kids if we need to here. There's still a monoclonal antibody infusion, something called bebletovimab. Say that 10 times quickly. And so we do have things that we can use to treat people who are high risk, but obviously prevention is best. So as many people vaccinated as possible, with 3rd and 4th doses with the most up-to-date vaccine will be helpful. if we were really going to be serious about protecting those kids, the people who are around them should be wearing masks. It's going to be very difficult to get everybody to agree to wearing masks. Those kids and families should be encouraged themselves to be wearing masks. We should be making it completely socially acceptable for those who wish to wear a mask or who need to wear a mask to wear them, you know, hand hygiene, all of that. And yes, I mean, you could certainly, you could space desks out as much as you can. You certainly don't want to single out one poor kid and put them in the corner, you know, that poor child sitting in the corner wearing a mask all by themselves. But, you know, within reason, these non-pharmaceutical interventions have worked for us over the past 2 years, right? I mean, we showed in the first 2 years of this pandemic that transmission within schools could be limited. And so these non-pharmaceutical interventions do work. They may work a little less well now that the virus is a little, you know, has become more transmissible over the last year or two. But I still think that all of those things, the layered protection is what we've also been talking about, right? Is that you've got, you know, pharmaceutical, and then you've got these non-pharmaceutical interventions. So whatever makes people comfortable, it's good to know though that there is backup with treatments. We also have it, I didn't mention, remdesivir given very early. Unfortunately, it's intravenous in the course of an illness can prevent progression of disease. And these work really well. So thankfully, we have other things that we can do to keep people from getting very sick, even if they do acquire COVID. But yes, prevention through all the means. There's really nothing new. It's all the same things that we've been doing.
And I will wrap up the coronavirus part by saying that our website, lebonheur.org/coronavirus, we will post some things there and give some updated guidance. But I want to ask one more question of Dr. Arnold about monkeypox. Do you have any top thoughts? We did have a question on monkeypox, and I thought you might have a thing or two to say about that, and then we'll let Mary McDonald close us out.
Sure. So everybody's really worried about monkeypox and whatever comes after monkeypox and what comes after that, right? So, you know, the more we encroach on the environment of the animals, the more they will get back at us by spreading their viruses to us. So we do need to be prepared that this has been going on in our lives for a long time, and it's going to be continuing. And so what I would say about monkeypox is that this is not nearly as transmissible as coronavirus. You're not going to get this by sitting in the same room with somebody in the same way that you can contract coronavirus, even though it is. So the way it is spread is by contact with infected lesions, so skin lesions, which can occur anywhere on the body. Although these newer strains, the lesions are not as widespread. It's not all over the body like smallpox or previous monkeypox outbreaks. So it can be kept covered with clothes, but your clothes and your bed sheets and your environment can be contaminated, and you can acquire infection from the environment. But you need to be, that's much closer contact than, say, at school or something like that. Obviously, anybody with a weird skin rash probably needs to see their doctor and not come to school until somebody has a look at it and decides if it's something strange or not. It is in respiratory secretions as well, but again, not spreading through the air. It's in droplets, and you really have to have close, prolonged contact with respiratory secretions. If you go to the CDC website, really a lot of the things that they're talking about in terms of protection are around prevention of sexual transmission, because that's the way it's been spreading mostly, not through the kinds of close, intimate contact you have during intercourse or at parties where people are very close to each other, shouting, kissing, these sorts of things, that sort of close, intimate contact. So the chances that it's going to get into a school and spread around a school are very small. And children are kind of getting it incidentally, probably from the home, from family members who don't know what they have, probably with contact with the environment in those cases. So while cases continue to increase and we do need to be vigilant, I don't think that this certainly isn't something we need to worry about in schools right now. And I don't think it's something that's going to spread rampantly within schools. But again, we do need to remain vigilant. There have only been 2 cases in kids in the entire country so far, less than 0.1% of cases. So this is not something I'm terribly worried about in pediatrics right now, but let's keep our eyes on it and see how it goes. Luckily, not nearly as transmissible as the coronavirus.
Okay, thank you very much, Dr. Arnold, and to all of our panelists. I will kick it over to Mary McDonald to close us out, please.
Thank you very much. And thank you, all of you at the school communities, for being a part of this Back to School Safely Task Force webinar. Your participation today is a strong indication of your desire and your commitment to providing a safe learning environment for your school community. And not only do we appreciate you doing that, but so do your parents, your students, your faculty, your staff. It's a great deal of trust that they place in you in making your decisions. And our goal here is to assist you in making well-informed decisions for your school community. To our task force from Bonheur UT, thank you. Thank you from the bottom of all of our hearts for your time, your expertise, and your guidance at this webinar today. And in light of the constantly changing landscape in health issues, we are considering making this task force a more permanent resource for you in your school communities, whether it is a health-related topic or any topic that your school or your community or classrooms are interested in learning more about. We would be willing to have these webinars or also come to your school or to a class to address those topics so that people feel that they have a resource in us and that they have a safe learning environment for the children. So you will be receiving an email tomorrow. And in the email, you'll have a link to today's webinar and also information about the topics that were talked about today. We would like you to respond to us in that and suggest whether you see this as a permanent resource that you would call upon, and what other topics you would like to learn more about, or what other topics would you like us to come to your school to address. This is a resource that we are very proud and honored to offer to the community, and we want to make sure that we address your needs. Sometimes we think we have those questions that you're going to ask, but it always winds up that we don't. We don't have them all. So if you input to us, then we're able to address whatever it is that you need. So again, thank you to our wonderful panelists today. Thank you for being such great supporters of the community when it comes to ensuring that schools have a safe learning environment. And thank you to all of you who participated. Without your participation, your schools would not be as safe as you are making them now. So thank you. And please take care. And as Tony always says, wash your hands. Make sure you wash your hands and check out the Bonheur website. So thank you very much. Yes. Thank you.
Thank you.